Hi, everyone. I'm Ashley Reinhart. I'm going to talk about a case study of a patient that has gone through our home monitoring program. Our objectives today, we're going to review this case study, review our home monitoring pathway, and discuss red flags. All right, our patient, case KD, at 18 weeks, 3 days gestation, our patient's mom had her first consult at the maternal fetal medicine office, where there was concern of the aorta arising from the right ventricle, a small pulmonary artery, and small ventricular septal defect. As you can see over here to the side, I've got what a normal fetal echo looks like, where you've got good 4 chambers, and then down here you can see a small right ventricle. That aorta is there overriding that septum, and there is a VSD there as well. And then the picture to the side, you can see that the pulmonary artery is quite a bit smaller than the aorta. They also, during fetal stage, they did a DNA testing that showed increased risk for 22q11 deletion, which is George syndrome, which showed that she was increased risk for that. And then at that point, the MFM office will refer them to our fetal cardiologist. So mom underwent her initial cardiology fetal consult at 22 weeks gestation, which is usually around the time that we typically do them. Usually around 20 to 24 weeks is when we'll do our initial consults. There, the fetal echocardiogram, pulmonary. So with the tetralogy of flow, you get those four things that there was concern about: VSD, aortic override, pulmonary stenosis, and then you get RVH, thickening of the right ventricular wall. At that point, the fetal cardiologist will alert myself or another member of our home monitoring team of a potential patient that will be in our home monitoring program once they undergo their initial surgery. So that way we can meet them fetally and get them as prepared as they can be. So who do we follow? What population of patients do we follow in our home monitoring program? Anywhere from shunt patients, which can be a Blalock-Taussig shunt. Oh, sorry. Hold on. A sono shunt, which is like an RV to pulmonary artery. Artificial tube, we can do PDA stents, we follow them as well, and then pulmonary artery bands, or if we've had a stent to right ventricular outflow tract. Those are all patients that we follow within our home monitoring program. So pathway at the second single cardiology consult. So usually the fetal cardiologist, once they initially see these patients, they'll see them every 4 weeks. So at that next visit, we have a meet the team day, which we started here around 2 years ago. And the family or caregivers of the baby that's going to be born with congenital heart disease will meet everybody that's going to help take care of them in the hospital. So they'll have their consult with a fetal cardiologist. They meet with a neonatologist, the CV surgeon, usually an attending from the CICU. Myself, and I have 2 nurses that work with me, our nurse navigator, hearts and hands team, child life. So it's a long day. They come in one room and everybody comes to meet them. We also provide them with a red binder that has lots of information in there on how to prepare them for this delivery and what things are going to look like afterwards. The red binder we've used for several years now. We used to not give it until they were getting ready, the patients were getting ready to be discharged, but we've been giving it early on, and feedback from that has been good. So families can get all the information ahead of time and do all the education and reading and be the most prepared they can be. They also get to tour the NICU, the pediatric CICU, and the PCU, which is our step down unit. So what is the home monitoring pathway? So all of our patients, once they're discharged, will go home with a scale, pulse oximeter, and either a iPad that we provide, or if they have a smartphone that has reliable cell service that they can use for data entry. We want to see these patients back. If they're a shunt, we see them in the outpatient cardiology office every 2 weeks. If they are a band or a PDA stent, then we usually will let them go every 3 to 4 weeks or sooner if needed. And then we do Locus Health data review. So if you see my screenshot over here to the side, families can enter their data. We expect them to do a daily weight, a daily sat, and a daily heart rate, and we can monitor trends. Before we went live with this home monitoring system, which will be 2 years coming up in September, we used to have families just write it down on paper, and once a week we would call them and they would give us their number. So this is a much nicer way and more reliable way that we can get this in real time, because I have an app on my phone that I can pull up and see these trends. As soon as they put a weight in, a sat, I can see that immediately. So it's a good way for us to make sure their saturations are staying within range and they're having good weight gain. With this, we will put a, for outpatient pediatricians that have access to Epic or any other specialties within Epic, our patients that we monitor, you'll be able to see a note in there that will demonstrate their trends and how things are looking. We also have someone on call for this specific population 24/7 that families are able to call or text at any time. So again, pathway. So we're following these patients every 2 to 4 weeks, depending on if they're a shunt versus a band or stent. If the patient is going to be a single ventricle, then they will need a cardiac cath pre-Glenn, because Glenn would be their second stage surgery, bidirectional Glenn, and they will have that around 3 to 4 months of age. Then we continue to follow them until their planned surgery, which is around 4 to 6 months of age. If the patient is going to be a 2 ventricle repair, which is like our case study patient, she's going to be a 2 ventricle repair. We will obtain a cardiac CT scan or cardiac cath if requested by the surgeons. And then these patients can either have their 2 ventricle repair as early as 4 months, or if they're doing well, gaining weight and doing well at home, then we can wait to as long as usually 8 months. Sorry, I'm not moving ahead for some reason to the next slide. There we go. So why do we follow these patients so close? We've started this program. It was developed to decrease interstage morbidity and mortality, as these patients are at risk of sudden death at home based on their physiology. So with a shunt, the shunt is their only blood source to their pulmonary arteries to their lungs. And so if something happens to the shunt, like a shunt thrombosis, if they get a clot in there, then it's an immediate, their decompensation at home, or as they grow, if it gets smaller with time. So that's why we follow their oxygen saturation specifically very closely, because we're going to look for trends to make sure that they're staying within the range that we want them to. So red flags that we have the families look for, if you're a specialist or pediatrician, on the outpatient side, these are things that we want you to be looking for and to alert our team. Family always has access to us so that they can call us with any concern. So oxygen saturations, we want to be greater than 70%. Sometimes, say if they typically live in the 80s, but now they're for some reason in the low 70s, even though that's within range, that's a change. So we want families to call us on that so we can try to figure out what's going on. If they have increased work of breathing, with retractions, cyanosis, if they didn't have that before and now we're concerned that the parents, they look more blue, sweating with feeds, weight loss for 3 consecutive days, they're more fussy than normal, vomiting, diarrhea, or feeding intolerance. So our little girl was born with tetralogy of Fallot, pulmonary atresia, that was confirmed with the echo right after delivery. She initially underwent placement of a 3.5 millimeter modified BTT shunt at day of life 2, which is a artificial tube or Gore-Tex tube from the right subclavian artery to the right pulmonary artery connection to establish blood flow to the lungs, since she has pulmonary atresia. There is a movie over here, Something the Lord Made. If you haven't seen that, that's a movie with the history of the Blaylock Taussig Thomas shunt. So I recommend watching that. That's a really good movie to gather the history on that surgery. So she did well, recovered from that surgery, went home. We were following her in our home monitoring. And our first visit, it was noticed that she had some decreased function of her right and left ventricle that had really not been there before. And so that was right at when she was 7 weeks old. She was also demonstrating feeding intolerance, poor weight gain, and she was tiring with feeds per the mom. And if you see the trend over here, we usually like to see a good steady upward trend on weight gain, and she was kind of all over the place. So there was concern there that, you know, something's going on. So we decided to admit her to the hospital and consult the heart failure team at that point. She was started on heart failure medications, including milrinone and Lasix. She was eventually transitioned from the milrinone to enalapril and carvedilol prior to going back home. The echo was mildly improved with initiation of these medications, and her symptoms had improved as well. Upon discharge, now she still needed to be in the home monitoring system because she still had the shunt in place, but now we have also some concern for heart failure. So she would need to follow both of our teams. So in our home monitoring system, we still followed her every 2 weeks to make sure that shunt remained open. At those visits, we always get an echocardiogram and EKG at every visit. And then she also followed with the heart failure team every 4 weeks for them to monitor her function. At 4 months of age, she eventually underwent complete repair of tetralogy of flow. At that point, they took down her shunt, they closed her VSD, and then they put in a right ventricle to pulmonary artery conduit, as you can see over here in the picture. So this is her now. She's 22 months old. Once a patient has their shunt taken down, PDA stent removed, we consider them graduated from our home monitoring program. So now she follows with our heart failure team still. She originally had a G-tube that has since been removed. She's eating everything by mouth. She's gaining weight. Her oxygen saturations at her last appointment were 100%, and she's doing very well. And that is all I have. Does anybody have any questions?
Nice presentation, Ashley. As far as you showed the red flags slide, what are the red flags that give you the most concern for acute problems that makes you want to direct the patients to the emergency room or a higher level of care that you get called with or texted on or receive messages about?
Yeah, good question. So the patient's families have the pulse oximeter at home to be able to monitor the oxygen saturations. We don't require that they leave it on all the time, just spot checks. A lot of our families will leave it on all night. And so the big concerns for me is whenever, like I said, if we have a kid that saturations are typically in the 80s, and now all of a sudden they're in the low 70s or even high 60s, that is a red flag to me that what's going on. Is the shunt, is there a thrombus that's starting, or is there something that is limiting blood flow to the lungs? And so at that point, we would go ahead and bring them into the outpatient office and get an echo, or even to the emergency room. If I'm acutely concerned, like the patient also has other symptomatics, more cyanosis, increased work of breathing, I'm just going to go ahead and have them come to the emergency room for an evaluation. And a lot of times when we meet these families fetally, I tell them we have a low threshold to admit you because we want to make sure everything's okay. So maybe we come in, we admit them for observation, we do an echo, everything ends up being okay, but at least we've got them here in case there was to happen to be a shunt thrombosis.
Great. And what are some kind of common screening questions you think that are good for our general pediatrician audience that they can ask their single ventricle patients if they're coming in for other visits and other reasons, but to make sure they're doing well from a cardiac standpoint?
Yeah, one thing I feel like our patients really struggle with that general pediatricians might see is feeding, you know, and they're going to be getting a weight, plus we get our daily weights, but I feel like I do hear a lot from pediatricians about weight gain. They're not gaining weight. We have a dietitian on our team also that helps us guide if we need to increase caloric density of feeds, or if we have a G-tube, can we go ahead and increase up on volume? But sometimes we're limited if we don't have a feeding tube and the kid is PO fed, and weight gain is an issue. Sometimes we've had to bring them in for an NG tube placement. So we do discharge kids home with NG tubes as well. That will take some feedings by mouth. So I feel like, you know, make sure weight gain, they're eating the appropriate amount, are good screening questions. And then also if they've had any concerns of cyanosis or increased work of breathing, those are all red flags that they could ask about.
All right, great. Thanks, Ashley.